Hello, my name is Dr. Joanne Sinelga, and I'll be presenting increase in all-cause mortality and syndromic surveillance monitoring. So the object of my study was to look at a retrospective longitudinal study to determine sepsis-like syndromes if it's attributed to COVID-19 mortality. The question would look into addressing the Framingham CDC methodology that came out in October 2020 during the pandemic, and it showed um, it divided the mortality rate from highest, like number top five mortalities. So one of the top five were diabetes, cancer, heart attack, MI, um, sepsis-like syndrome, which was number five. So I did look at sepsis and it was number five according to the Framingham methodology. But why was it number five? And we do know that other upper respiratory infections must also be included in this syndromic surveillance. The sepsis kind of captures more of an overall infection, and we know that COVID and sepsis do look alike. So I kind of wanted to also introduce something we call syndromic surveillance. Syndromic surveillance, when you think of it, it has been used in wars to kind of detect, but it's a method where it employs past. If you see an increase in a syndrome that you haven't seen, then that triggers the system to be reported through this HL7 EHR, and it directs that towards the public health department to be alerted to look into this increase in this symptom that has not been as usual. So we do know that sepsis also increased in during COVID-19 pandemic, where if we look at the 2019 data, it increased about 20%. So why aren't we adding sepsis-like syndrome into the variable? So the current variables that we do have, those include um, pneumonia-like symptoms, flu-like symptoms, and COVID-like symptoms. So those are the things that are reported from the ED urgent care to the department. But sepsis-like syndromes is not added, and therefore this is accounting. We're not getting a clear picture of what COVID-19 mortality looks like. As of March 31st, 2021, actually, COVID made it into the top five, which was not the case when we looked at the October data. So there is an improvement where, the data analysts are actually looking closely into this and kind of capturing more cases towards COVID. There was an argument in the past also as well, where the public were saying that we're overcounting COVID, and that is not the case. We're truly undercounting COVID-19 mortality. And so number three, it making number three with all cause mortality, that is a step in the right. So So when we look at this picture over here, I kind of realize that whenever I press make the screen bigger, that actually it stops. But when we look at this, we look at the patient comes in and the patient says, I have flu. The patient doesn't say that, but the patient says that, I've had runny nose, and we ask for how long. So during that time frame that is defined from COVID to the flu, we can tell exactly what it is. And this data goes into our EMR, in this case, Epic, right? So and then Epic, that data, the way it goes to the public health department is through this software, or it's called HL7. And so the HL7 has to be conformed to get to the public health departments. When it gets to the public health departments, so the data analyst will look at three endpoints. and in the COVID-19 surveillance, right? So they will look at flu-like symptoms, they will look at pneumonia-like symptoms. So they're looking at upper respiratory infections, lower respiratory infections, and then after that, they will look at our COVID-19 efforts moving forward, or are they, should we enforce, quarantine to control this situation? So that is how they make up this data. So one of my proposed, I guess, um, study is to add sepsis-like symptoms into these variables, and therefore we would be able to get a clear picture of more of, since it's an overall infection, right? So we would get a clear picture of the syndromes as a result. So my methodology, I kind of got that data from the Framingham method study and the vital statistics, and I looked at um, I looked at several endpoints and what influence more of um, what might contribute more to our COVID-19 in order to have more of a clear, precise picture towards COVID-19 mortality. And so, in addition to this, one of the things that I we looked at, from this is from the March 31st, 2021 database. And as we can see, 75 to 84 and 85 to 125 almost take up almost the end of the pie, that there are the ones the leading cause of all-cause mortality in this age group, and that is usually the case. But we know that this age group also suffered from COVID-19 the most. So there, if in the past, some of the death, the excess mortality is 650,000. That means that almost more than 489 of deaths went into this age group pie chart. And so if we look at, again, the all-cause mortality, we can see that the age group of 85 went way too high if you look at it. So that kind of gives you a more picture of, and here I looked at all-cause mortality, COVID-19, and then we looked at upper respiratory infections overall, and still those infections showed more increase in death from 2019 to 2020. Um, and this is something we call the tableau, which is, I cannot play with it here because I transferred this to the PowerPoint. But if we played along with it, those stars those asterisks, when we see them, as you can see from September to January, the all-cause mortality death increased if you look at it, and it keeps increasing. But around January, that is when most death happened, which was quite interesting when I looked at this data. And so I kind of wanted to reiterate what how syndromic surveillance works. So it comes from the clinical care, which would be the emergency departments. And there is so many things that can go in place. So when we look at lab orders, that is where you see the COVID-19 variances. That's how we can detect those. And there is a separate database, and there is genetic epidemiologists who kind of deal with this situation to look at if, it's important to know the variants because, we want to know if our vaccines are working or not, right? And then that goes to the jurisdiction lab system. So jurisdiction meaning where you're located at. So like I'm located right now in Chicago, so that would go towards the Chicago Department of Public Health. But then when I move 5 miles away, then I'll be located in Cook County. So that hospital that is located there they have to transmit that data to the Cook County Department of Public Health, which is totally different in the way they act and their policies and finances and social determinants of health and inequality, as you can imagine. It comes from state, then to local jurisdictions, and so on and so on. So then that data also can be also we can do vaccination. That's how we can look at vaccination uptake, their certificate. All this data is kind of reported in different uh, areas, and I have used all of these um, surveys to say this data points. So the National Center for Health Statistics, which is where you look at mortality, and that is where I got that data. But if I was looking at different variables for different reasons, right? Then I would look at, let's say, national syndromic surveillance, and then national notifiable disease surveillance. That is, if you're reporting any reportable disease. So in our jurisdiction, STIs are very more common. So and that is, thank you for listening to my recording. And if you have any questions, feel free to reach out through my SAM email system. Thank you so much. And these are the references.